We start in Lecture of Pediatric Pelvic Mass, which divided into cystic and solid masses. The cystic are usually congenital genitourinary anomaly. First in both sex urachal anomaly and rectal duplication cyst. Second in girls hydrohematometrocolpose and ovarian dermoid. The last in boys Mullerian duct cyst and prostatic utricle cyst. The solid mass usually neoplasm as rhabdomyosarcoma or sacrococcygeal teratoma. We start in cystic lesion in both sex genitourinary anomalies. Urachal anomalies. We see fluoroscopic image cystogram. Pelvic axial CT scan with contrast. Ultrasound image. Sagittal CT scan of abdominal and pelvic. There is 4 different types. First, patent urachus from bladder to umbilicus fistula is most common. Second, urachal cyst is isolated cyst. Third, urachal sinus is blind umbilical tract. The last one is vesicourachal diverticulum is bladder diverticulum. Their incidence of increased risk adenocarcinoma if untreated. The second cystic lesion can occur in both sex is rectal duplication cyst. Abdominal and pelvic sagittal CT scan with contrast. Pelvic sagittal CT scan with contrast. The rectal duplication cyst is retrorectal cystic mass, usually resected due to malignant potential. Etiology: congenital abnormal budding of GI tract. May communicate with bowel lumen. Imaging. Ultrasound classic finding are cystic or tubular lesion, gut signature or enteric signature, hyperechoic inner mucosal layer with outer layer echogenic rim sign. Now we go to cystic lesion. They occur exclusively in girls patient, only reproductive tract obstruction. The first pelvic cystic lesion in girls here. Sagittal MRI T2 weighted image. Ultrasound. Hydrometrocolpose spectrum. Cause: outflow obstruction plus hormonal stimulation. Types: hydrocolpose is fluid only in vagina. Hydrometrocolpose is fluid in both uterus and vagina. Hematometrocolpose is a blood at menarche due to imperforate hymen. The second pelvic cystic lesion in girls here. Abdominal and pelvic CT scan with contrast. Coronal. Sagittal and axial of the pelvic. Ovarian dermoid or teratoma. CT scan shows the following: fat-containing ovarian mass, fat fluid level and tooth calcification, hair and Rokitansky protuberance. Size greater than 10 centimeters or irregular soft tissue is suspect of malignancy. If rupture occur, fat droplets under diaphragm. Chemical peritonitis. Now we go to pelvic cystic lesion occur exclusively in boys only Mullerian remnants. There are MRI T2 weighted images coronal axial and sagittal. We see intraprostatic Mullerian duct cyst. On imaging, midline cystic lesion in prostate. Seen on ultrasound and MRI. Does not communicate with urethra. Think here the rectal duplication cyst is communicated with urethra. May contain hemorrhage or pus if infected. We see different images of retrograde cystoscopy. See this. See this. See this. Prostatic utricle cyst. With hypospadias and can become large. The pelvic cystic lesion incompleted. We will start in solid pelvic masses. This image pelvic axial CT scan. Coronal MRI T2 weighted image. Uterine rhabdomyosarcoma. Most common pediatric sarcoma, but is a rare aggressive uterine sarcoma. Sites: pelvis and head neck 80%. Clinically appear as postmenopausal bleeding and vaginal pelvic mass. MRI findings. Large polypoid uterine mass. Extends into cervix vagina. T1 low signal. T2 heterogeneous high signal. Restricted diffusion. Heterogeneous enhancement. Fibrovascular stalk may be seen. There are two types: embryonal is better prognosis and pleomorphic alveolar is aggressive. Treatment: surgery, chemotherapy, and radiotherapy. The last pelvic solid mass lesion. We see MRI multi-sequences. Axial T1. Coronal T2 stir. Axial T2 fat sat. Axial T2 fat sat. Sagittal T1 with contrast fat sat. The images show sacrococcygeal teratoma feature. Most common neonatal tumor. Often prenatal diagnosis. Mixed content cystic solid and fat. External buttock mass.